Good afternoon and welcome to this session. I'm Dr. Sam Berlin-Jerry. I'm standing in for Ziting Lee, who's got another commitment. So this is the breast oncology session. So just to check your schedule that you're in the correct location. And the first speaker is Dr. Stephen Lewin, who will give us a clinician's overview of breast carcinoma. Welcome, Stephen.
Thank you. I just need to work out this. I've been given the unlucky task, I guess, perhaps, of trying to put together an overview of breast cancer from a clinician's perspective within half an hour, which is quite a challenge, as you'd expect. My name's Stephen Lewin. I'm a medical oncologist at Peter Mac, and hopefully these slides will go forward. So I guess today I've been given a few learning objectives, but what I really wanted to do, I guess, within the half-hour time frame is to just come up with some concepts rather than going to details. And so these are the learning objectives that were provided to me. Number one, to provide an overview of the best practice in clinical management of breast cancer patients. Number two, to discuss the implications of staging and management of breast cancer. And number three, to discuss the roles of nuclear medicine in the standard management of breast cancer. So I'm going to cover these points really quickly because what I also wanted to cover was perhaps some emerging concepts that are certainly interesting, at least from a clinician's point of view. And so this is basically the gist of the treatment paradigms of which we look at breast cancer as a clinician, and you can see it's this clear dichotomy between that of early breast cancer and that of metastatic breast cancer. And I guess it's sort of fairly severe in that as soon as you flick off a distant metastasis, that you've really reached that point of no return, and you then go into this metastatic breast cancer subgroup on the right, as you can see on the slide. And so you can see for each of those two entities, there is a difference in the way the intent of the treatment. So with the left, if you have early stage breast cancer, the aim, of course, is to cure. Whereas with metastatic breast cancer, the aim is to control. And so with early breast cancer, of course, the standard approach is to have surgery first, although neoadjuvant therapy is becoming more common. I'll talk a bit about that later. You'll have your surgery. We'll take some prognostic variables as well as some variables that predict response to therapy. And you'll often be discussed in a multidisciplinary meeting, and decisions will be made as to whether chemotherapy, endocrine therapy will be recommended, after which you'll then go into the surveillance phase. Metastatic breast cancer, of course, is a little bit different. Surgery plays a less defined role, but again, it comes down to these prognostic and predictive biomarkers to help us understand how we're going to treat these patients. Should we treat them with a sequential single-agent treatment approach, which is generally the recommended approach, or are we going to use a combination approach to get a more rapid response? And certainly, most patients will have a sequential single-agent treatment approach, although a lot of clinical trials are now pushing more into the combination treatment approach. And I guess this is just a summary slide to sort of show one of the difficulties in which that we have in breast cancer, particularly in hormone receptor positive breast cancer, in that over the years we've developed all these different trials that have shown survival benefits of many different agents, chemotherapy on the top and endocrine therapies on the bottom. Some of them are for 5 years, some of them are for 10 years, and so we've had these incremental gains in survival. But it becomes very difficult for us to know exactly which agent to use, and that's because we don't have good predictive biomarkers to tell us exactly who's going to benefit from what therapy. And so the consequence of this is that we generally have over-treatment of our patients. And I'd like to think that that's improving, and certainly there's a number of gene expression assays that have been looked at that have been designed to aid the clinician in deciding whether a patient's going to benefit or not benefit from adjuvant chemotherapy, and those have largely been applied in retrospective analysis of trials, and there are some prospective trials coming through, some of which some results might be coming through at ASCO this year. On the other hand, with the endocrine therapy options, we really have very poor predictive biomarkers. The guidelines suggest if you have 1% or more hormone receptor staining, you should have some form of endocrine therapy. But the menu of endocrine therapies has really opened up massively with tamoxifen. You've got steroidal and non-steroidal aromatase inhibitors. You need to consider whether to add ovarian function suppression. And then there's a whole bunch of new agents in trials such as CDK4/6 inhibitors and PARP inhibitors for selected patients. And moving on to the metastatic setting, it becomes very nuanced. And I guess to give you a brief overview, basically it comes down to the patient you have in front of you and all those factors and whether you need a rapid response. And by that, I mean if you have a patient who has bulky metastatic disease, for example, with multiple liver metastases, and you see that the liver function tests are deranged and the bilirubin's slightly off, you're going to be concerned that that patient will rapidly progress and perhaps go into liver failure, and that can be fatal. And so in this case, you would want a rapid response and you would go for combination systemic therapy. However, most patients fall into this no rapid response necessarily required at the time, and we generally go for a sequential single-agent systemic therapy approach, and that's really with the aim, again, to control the cancer for as long as you can, improve symptoms, and maintain quality of life. And the optimal choice of first-line therapy is pretty unclear, but it depends on a variety of factors, including recurrence-free interval, prior therapy, performance status, availability of clinical trials, the presence and the distribution of metastases, comorbid conditions, toxicity, and patient preference. So that's 3 slides on the first 2 learning objectives. And moving on to the next one, which is to discuss the roles of nuclear medicine in the standard management of breast cancer. I'm just going to go over, again, 3 slides to look at the recommendations for staging. So what you'll notice about the guidelines on staging is that a lot of it is based on quite old evidence. So the AJCC staging edition 7 is really quite reliant on anatomical staging, and so that's the TNM system. And so a lot of the studies have looked at that, and these studies looking at the benefit of performing scans have really looked at quite old cohorts of patients. So I think realistically, moving forward, we might need to re-examine these concepts. But essentially, if you are stage 1 or 2 and you're asymptomatic, a staging CT, bone scan, or PET scan is not recommended, whereas with stage 3 disease, it is recommended, plus or minus a PET scan. And the reasons for that is that there is a lack of evidence for benefit in these older trials, and there's this thought that unnecessary imaging can potentially lead to harm. And then when a patient moves into the surveillance phase after all their adjuvant therapy, again, there's no recommendation to perform any scans, and this can be a very tricky thing to negotiate with patients, and they're often anxious and they often pop up symptoms here or there if you ask them about them. The other thing that is not recommended, of course, is tumor markers, and again, this comes down to a lack of evidence for benefit, and this thought that false positive results can potentially lead to harm. And then for the guidelines with metastatic disease, it's pretty open, but basically we would routinely order staging scans in patients with metastatic disease to define the extent of their disease, usually with a CT and a bone scan. And PET scans could be considered if staging studies are equivocal or suspicious. At least that's the recommendations of the guidelines. And certainly I think certain centres will be more inclined to perform PET scans than others. And that was really my talk on those learning objectives. What I really wanted to talk about, which is a bit more interesting for me at least, is these emerging concepts in the treatment of breast cancer. So firstly, just to sort of summarize it, is this transition to precision medicine and how that's incorporated into the way we think. And also, I wanted to talk a little bit about neoadjuvant approaches in early stage breast cancer. I wanted to talk about the detection of minimal residual disease and with its potential to detect early relapse, oligometastatic disease, and finally, predicting treatment benefit and early detection of treatment resistance in metastatic disease. So this is just a summary slide, but the basics of it is that, again, going back to what I said before, is that a lot of the way we manage patients is largely based on anatomical staging, and the premise of that, of course, is that increasing tumor burden is associated with worse prognosis. So in early stage breast cancer, that's the tumor size, chest wall invasion, nodal involvement, and in metastatic disease, that's the number of metastases and the presence of visceral versus non-visceral and where they are, the metastases. But more and more, we need to think about incorporating these biological factors. And the premise of that, of course, is that more aggressive disease is associated with worse prognosis too. And that these factors, the tumor burden and the biology, they're somewhat overlapping, but they've also got independent value. So in early stage breast cancer, that's the tumor phenotype. Is it triple negative? Is it HER2 positive? Is it hormone receptor positive? We want to look at the grade and Ki67, which has sort of struggled to find a foothold because of its potential issues with reproducibility. And then in metastatic breast cancer, it really comes down to things like how soon did they relapse after their definitive therapy and their prior treatment exposures. And this is a flow diagram sort of explaining this transition, but basically a patient will come in with a cancer diagnosis, upon which they will then have a prospective biomarker evaluation. And we need to really move beyond just the tumor itself. So, of course, we've looked quite deeply into the tumor intrinsic biomarkers. So most of those that have been published have really looked at gene expression, for example, the intrinsic subtypes and these gene expression recurrence scores. But we and other groups have also started to look at changes at the DNA level, because those are looking at the actual driver oncogenes that are present in the primary tumor and whether those have an influence on the biology of the tumor. But moving outside of that, you've then also got host-specific biomarkers. There's a lot of new stuff coming out with pharmacogenomics, but we also need to think about lowering our threshold for testing for cancer susceptibility genes, such as DNA repair genes BRCA1 and BRCA2, certainly because in the metastatic setting, we're now finding that these biomarkers not only provide important familial information, but also that they can predict benefit from certain therapies, such as with PARP inhibitors or platinum agents. And so if you can deliver this a bit earlier and you can improve their prospects of cure, that could be very valuable. And finally, my lab has a particular interest in the tumor microenvironment as well. So in particular, tumor infiltration, immune infiltrations have been looked at in great detail, and certainly they're quite prognostic, particularly in triple negative breast cancer and HER2 positive breast cancer. But can we look a bit further than that? Can we look at the immune checkpoints, and are there a subset of patients who might benefit from earlier treatment with these immune agents and perhaps achieve higher rates of cure? And so the idea is that if you can take all these markers, you can then come up with a personalized treatment plan. Now, we're pretty far away from that, but this is the start of where we'd like to be heading. Another emerging concept, of course, is neoadjuvant treatment approaches, and this is a little bit of a complicated slide, but I'll just sort of try to take you through the value of neoadjuvant treatment. I'm sure most of you know a bit about it. It's been around for a long time, but we've really sort of developed our biomarker analysis in these trials. And so the idea, if you look at the top half of the slide, is that you get your diagnostic biopsy, and then you receive some form of neoadjuvant therapy, which is, I guess, defined as a systemic therapy of some sort prior to surgery, and this is all of curative intent. So you'll provide your neoadjuvant chemotherapy, plus or minus a targeted agent, and you'll have your definitive surgery. And the big bonus with a neoadjuvant approach is that you get more information than a upfront surgical approach. In particular, the one that's been most talked about is the complete pathological response. So if you have a complete pathological response, you have a much more favorable prognosis than if you have residual disease at the time of surgery. And this is really important for prognosticating patients or stratifying by prognosis, because it might inform as to whether you need to provide more therapy after surgery. But the other thing it does is it also provides biological information. So if you have a complete pathological response, it tells you a little bit about the tumor itself and that it's susceptible to the treatment that you've provided, and that can be valuable. And whereas if you have residual disease, perhaps it goes to show that there is some evidence of resistance to treatment, at least in some subclones of the tumor. It is important to note, though, that PCR, it definitely is significantly associated with improved prognosis, but as yet, PCR itself is not a validated surrogate endpoint for improved survival endpoints. And what I mean by that is that if you have a novel agent and you apply it in the neoadjuvant setting and you increase the rate of which you have a complete pathological response, it does not necessarily mean you have improved survival as yet. So we need a better surrogate endpoint. And for me, I think that's really it's perhaps the holy grail of the neoadjuvant setting, because if you can have a really good surrogate endpoint, you can then develop drugs a lot quicker because you don't need to necessarily wait for events. And in terms of the biomarker analysis side of things at the bottom part of that page, so my lab often looks at these neoadjuvant trials, and we'll do the pre-treatment biopsies, on-treatment biopsies, and post-treatment biopsies, and we've certainly found that that can provide very valuable information. But there's other biomarkers out there that people are looking at, including circulating biomarkers, for example, circulating tumor DNA, which some of you might have heard of in this conference, but also I think imaging modalities such as PET have been really looked at as well, such as the metabolic response while on the neoadjuvant treatment. And this is an example of that I just saw recently published that is essentially looking at the predicting neoadjuvant treatment outcomes. This group performed PET scans before neoadjuvant therapy and an interval PET scan. I can't remember the exact timing, but I think it was somewhere between 2 and 3 weeks after they started their systemic therapy, and they looked at metabolic response, and you can see from the plot A on the left that indeed if you had a favourable metabolic response, you had a favourable survival outcome, and that was significant, and that it mirrored what we saw with the PCR rate. So I guess what I'm trying to say is if you can perhaps put these points together, you can come up with better surrogate endpoints and more refined prognostic detail for the patients. Another emerging concept is this idea of minimal residual disease and early recurrence. Again, it's talking about circulating tumor DNA, so this is the liquid biopsy. This is a study schema shown on the left by Nick Turner and his group, where they took, again, neoadjuvant chemotherapy in breast cancer patients. They performed multiple tests, but they looked at circulating tumor DNA before the treatment, but also after surgery. And then they followed those patients up as a means of surveillance with the circulating tumor DNA. And what they found was quite interesting, because they found that if you had a positive ctDNA result, that is, you found the mutation present in blood, this increased your sensitivity for prediction of relapse with a median lead time of 7.9 months over clinical relapse. And certainly from a clinician's point of view, 7.9 months is a substantial amount of time in the lifetime of a metastatic breast cancer patient. And hopefully it's a meaningful amount of time to be able to make a difference in survival and also other factors. And so on the right is a sort of a flow diagram of a schema that a colleague of mine at Peter Mac is trying to design as a clinical trial, which is essentially to take high-risk breast cancer patients after they've received their definitive treatment and to look at doing serial ctDNA testing to look for this minimal residual disease. And then if you do find a mutation, the question is, what is the clinical significance? So what we want to do is then chase that result. And probably to do that, the next step would be to do as sensitive as a scan we can do, such as a PET scan. And if that comes back as positive, you should then biopsy it if it's feasible and provide some sort of a tailored treatment plan on the basis of that. If the PET scan's negative, the idea of the trial is certainly to just continue surveillance with serial liquid biopsies. Another interesting concept is this idea of oligometastatic disease at diagnosis. So I guess probably many of you will sort of have seen some of these novel approaches coming in other cancer types. But the idea of oligometastatic disease is that it's low-volume metastatic disease of a limited number and size that is potentially amenable for local treatment aimed at achieving a complete remission. So again, the idea is to perform your best staging scans up front, perhaps an earlier stage disease than we might have before. And if you have no metastatic disease, you would go on and have your definitive loco-regional treatment. If you have widespread metastases, you could go on and have your palliative systemic therapy as per the normal guidelines. Whereas if you have oligometastatic disease, particularly with the advent of things like SABR, which is able to deliver ablative treatment, you could provide an aggressive upfront treatment with definitive loco-regional treatment of the breast, as well as local treatment to the oligometastasis. And the hope, of course, is that this may provide prolonged disease control or even potentially cure in selected patients. And I say that very carefully because selection is the key for these patients. And one of these, as an example of this sort of approach, at Peter Mac, we ran a pilot trial called Boston 2, where essentially we took breast cancer patients with oligometastatic disease, and they all had a CT, a bone scan, and a PET scan, and if they had evidence of oligometastasis, which was limited to 1 to 5 metastatic lesions in this study, with at least one deemed suitable for SABR, you would go on and have SABR to at least one of those metastases. And certainly in the patients that we did most of the oligometastatic lesions received SABR, so it was usually more than one metastasis that had that. And to leverage the treatment with radiotherapy, what we did was we also added 6 months of pembrolizumab. And the rationale behind that is that radiotherapy and immune checkpoint blockade have been shown to be synergistic, at least in preclinical models. And further to that, that checkpoint blockade is perhaps more effective in earlier stage disease and with less disease burden. And so we've performed this in 15 patients, and certainly there doesn't appear to be any safety issues. So we're interested in seeing if these patients do very well from a survival standpoint, because that would be important. Another emerging concept is this idea of predicting treatment response and duration of benefit. So the concept is that a metabolic response seen on an interval PET scan might help inform the likelihood of treatment response and the duration of benefit. So I've just shown a schema here. So if you have a baseline PET and then you provide your systemic therapy, you then have an interval PET scan. If you have a favorable metabolic response, then that's a good thing. You might want to just continue with your therapy and continue to standard disease monitoring. Whereas if you have an unfavorable metabolic response, I guess there's two options. I haven't put this here. One is to go for a more intensive disease monitoring approach, or even if you're that confident about the unfavorability of the metabolic response, to really change the agent to something you think might be more suitable. And as an example of a way to sort of more intensely follow a cancer, again, I'm talking about circulating tumor DNA, is to perform these liquid biopsies perhaps more frequently, because the real advantage, the other key advantage of circulating tumor DNA is that if you are aware of the certain types of resistance mechanisms, at least at the DNA level, you can design a ctDNA panel to follow that in blood to help you decide whether these resistance mechanisms are arising. So as an example of that, you can see that bottom plot at the bottom right from Sarah Jane Dawson's article in New England Journal. You can see that the patient had responded up to day 42, but you can see this ESR1 mutation rising. ESR1 mutations, of course, have been described to be to confer estrogen-independent ER signaling, and so this is a resistance mechanism to things like endocrine therapies. And so just to conclude, what I was talking about before is that the clinical management of breast cancer has really largely been guided by anatomical staging to date. And I think in this new era of precision medicine, we must really incorporate these biomarkers looking at the biology of the breast cancer as well. I'm quite fascinated by these novel nuclear medicine approaches and how they might be able to refine the estimates of prognosis in response to treatment. And I think ongoing studies into this are essential. And that's the end of my talk.
We have a few minutes, so if there are any questions from the floor, please step forward.
I would have a question from a clinical point or perspective. Do you and where do you see a clinical need for imaging biomarkers beyond FDG, like HER2 imaging or estrogen receptor imaging? Do you see a clinical need, and if yes, where in the treatment of or patient management?
Yeah, so I guess I don't have that much experience in these sorts of novel imaging sort of agents. I've mostly seen FDG PETs. I guess at our centre we've just started this trial using a novel SERD, so that's an estrogen receptor degrader. I guess it's like a next generation tamoxifen basically, and they use another type of tracer. I'm not exactly sure of the name, sorry, but I'm really fascinated by how these can predict response, because certainly I think if you can come up with a really good tracer, it just provides such valuable information for both the patient and the clinician. That's my perspective on it.
Okay. Thank you very much.
I think there's one question from the floor.
Just a comment. There wasn't much mentioned about radiotherapy in the talk, and I think when you're talking about early breast cancer, it's important to emphasise that it's a fundamental, cornerstone of cancer therapy, if we're talking about an overview of breast cancer therapy. So just to mention that.
Absolutely, totally agree with you. Unfortunately, I'm a medical oncologist, but I should have added those to my slides.
Okay. Just before we let you go, Stephen, we have a certificate for you.
So it's a real privilege to introduce the next speaker, Professor Francesco Giamarile, who will give us an overview of the potential of PET-CT in breast carcinoma. Thank you, Francesco.
Thank you very much, Christophe. So, dear friends and colleagues, before starting, I have 3 oral disclaimers. So the first, I don't know if you notice, I appear twice on the program today. It's not because of my ego. It's related to the fact that my colleague, Enrique Estrada, has made some confusion with travel and is now at the airport. So I don't know if you have experience of giving a speech prepared by someone else. And furthermore, in some slides are in Spanish, so it's not easy at all. I hope you will understand. The second, I am a nuclear oncologist, but my experience in breast PET is limited. So I hope you will forgive some eventual mistakes I will give. And the third, last but not least, the presentation is in Prezi. You probably don't know what it means. Enrique claims that is PowerPoint of tomorrow. The problem is that I have to give the presentation today. So I hope it will work. Thank you. So yes, this is so you see it's very nice. This is the incidence of breast cancer in the world, and we can say practically that breast cancer is the most common female cancer. And if we look at the incidence and the mortality, is also the most frequent cause of death for women in the whole world. We already saw that breast cancer has several receptors, and all those receptors can be used to have nice PET images. Some are known and used by several years. Some are really experienced research tracer. So from the most common is clearly the GLUT with FDG. So we know that FDG was introduced by the research of Otto Warburg that discovered in the 30s, exactly in 1924, that cancer is characterized by the increase of glucose transport and exokinase. Both those aspects implies that if we inject glucose to patient, the cancer cell will uptake this tracer, and the tracer will accumulate because we don't inject normal glucose but fluoroglucose, so the glucose will not follow the Krebs cycle as the normal glucose. So this is the metabolic, and if we look at the NCCN guidelines version 2016, we see that FDG has to be considered in case of clinical stage 3A, T3N1M0. Is an option, but we will see in our presentation that is not the unique indication in breast cancer. Since these are yes, okay. Since we can think on any use of FDG in the initial evaluation of breast cancer. This is a little bit more related to PEM, that is positron emission mammography. You know that PEM can be done with specific instrument, that is a small dedicated instrument, or even with normal whole body PET, if the patient has the breast in the right position. So we will see images that are done either with PEM or with the normal PET. So these are 2 slides showing mammography with the corresponding PET, and you see that there is a very nice correspondence between the mammography and the FDG PET images. If we look at, this is it was a infiltrant papillary carcinoma. If we look a little bit closer, and these are the two images, we can, I don't know if I go too quick and no, it's good. We can look at another patient. In this case, the mammography was non-conclusive, and these are the image. And if we do PET, we look at a very teeny uptake. This is not very evident in this image, but I will have other images that are, sorry, here, a little bit more big, and you see the uptake. So you see that in this case, PET was even more sensitive than mammography. This is another case with the same situation, with correspondence between mammography and FDG. This is the mammography. Those are the distortion showing lesion in left breast. And this is the correspondent FDG with an SUV that is low, 1.3, and 4, and 1 and 3.92, but it was a CDI. Now, this is another image that comes from an article that resumes the situation of primary breast cancer screening with positron emission mammography. So this was done with a dedicated PEM and whole body. And the detection you see in the description, for 265 women, we have 2.3% of cancer detection. And the true predictive value of PEM was 27.3, with a size that is very small, because it's 0.7, 1.2, and 2 centimeters. These are the image. Now, in conclusion for this part of initial evaluation of PET FDG for breast cancer, we have about several studies with more than 500 patients in total. And the advantage is that those studies show that FDG PET will give more information than classical screening with mammography in a consequent number of patients, because we go between 30% to 20%. That is something that is very interesting. We have both possibility of underscoring in this percentage from T4 and 0, this is overscoring from T4 and 0 to T4 and 3. And this is one example of one patient that's showing a positive lymph node in intermammary chain that was not previously noticed by the common diagnostic investigation. And also from the T3 and 2 M0 to T3 and 3 M1. And here we see a positive bone metastasis in a patient with several metastases, in particular in the ischion level. This is another article in triple negative breast cancer, where the patient has several lesions due to the high aggressiveness of the cancer. Here we have the positivity of PET. You see, the more the clinical stage, the more we see percentage of positivity in FDG. These are some examples with liver, bone, and lymph node lesion. The last aspect is related to the prognostic value of FDG, as this was already mentioned by the previous speaker. So you see two nice Kaplan-Meier curve, where if FDG is positive, this is the second curve, the mortality is higher. And the same was demonstrated with another tracer that is FES, that is an estrogen receptor binding tracer. In this case also, we have different survival curve if the patient was uptaking or not uptaking the FES. Here is the progression-free survival. And so the paper compared FES and FDG. In the first case, you see positivity in both cases, and there was 5 months until the progression. In the second patient, there was no FES, so no estrogen receptor, but the positive FDG. In this case, was a worst prognosis. Now, another possibility is to look only at the ER-positive, HER2 negative invasive breast cancer, also with FDG, and the results show that in case of high SUV, so the first patient, A and B, we have worse prognosis than the second, that was AB down under. And the third with no or little uptake was little. So here you see a nice correlation between SUV or also other parameters like total lesion glycolysis and prognosis for different cases. Now we move to FLT. FLT is fluorotimidine. Is one element that is used in DNA synthesis. So we can use fluorotimidine instead of FDG. The molecule is used since several years and it still has some interest in breast cancer, especially for therapy evaluation. So this is a case with 15 patients, and they show that after 1 week, just 1 week of one cycle of chemotherapy, it was possible to differentiate good responder than bad responder. And this is something very interesting. If we consider the toxicity and the price of chemotherapy, we can change a little bit, like, I don't know if you have the experience in lymphoma, this is done with FDG. This is an example of positive FLT at the first day before chemotherapy, and 7 days after chemotherapy, you see that the patient had negative or nearly negative uptake. We already spoken about FES, but if we look a little bit more in detail, HER2 receptor, we know that there are also more specific tracer that are like this one, ABY025 SPECT-CT. This is a tracer that is used for people who has no PET, so there is also room to do these studies with non-PET imaging tracer with very nice results if we compare with FDG PET-CT. So always about the estrogen receptor, we have the fact that we can follow now not the chemotherapy, but the estrogen therapy that my previous speaker already spoke about, and the efficacy of the uptake of FES with the efficacy of the response of the therapy, you see it's very nice. Here is a case with orbital cancer. It was actually a graft, but the FDG was not easy to interpret it because of a normal brain activity. The bone scan also is not easy to interpret it because of normal bone hyperactivity, but the FES is clearly positive, you see, in one spot in the orbital region. And the second patient has positive FDG and negative FES because of HR2 negative. This is the first patient, and this is the second. Now, other example of comparison between gallium, in this case it's gallium-67, so it's SPECT, it's not PET, but we could do also in PET, anti-HER2, FDG, and FES. So you see that the possibility of doing images and research with all those tracers is nearly infinite. Here are the different results. So now, this is an example. In this case, is gallium-68, so PET, anti-HER2 PET, and the result is this one. Here we have mammography. Here we have the HER, and you see that there is positivity of FDG, FES, and gallium DOTA anti-HER, but the expression of this positivity is not the same within the tumor, showing that the tumor has heterogeneous presence of receptor and also a heterogeneous activity in terms of glycolysis and DNA. And this was also proved by some histological studies like this one. Okay. This is another study comparing, I think, FDG, gallium, and I don't remember, maybe, I don't remember, I'm sorry. However, the message is the same. You can image in vivo, without doing biopsy, the expression of receptor. Now we have other tracer, like gallium RGD, that is an integrin molecule, and this also is a research molecule. We can have comparison between the activity and the tumor activity in this study. And here is an example of gallium RDG compared with FDG. You see that the lesions are comparable. This is a preclinical study in mouse. We see that we have another tracer, TRAP RGD, with uptake before and after treatment, that showing the in vivo monitoring of the therapeutic effect. And these are the results for several mice. We have before and after the treatment, how the uptake is decreasing, while the control group is not is unchanged. This is an example of a human study with the same molecule. Before and after treatment, you see that the uptake is clearly decreased. We move to androgen receptor, because clearly you know that breast cancer has also androgen receptor, and androgen receptor can also be targeted with PET. One case is fluorodihydrotestosterone, and this is the case of one patient. We have a comparison between androgen and estrogen receptor, and the comparison also between androgen receptor with the testosterone and estrogen receptor with estradiol in the two slides. You see that the information are completely different, because it was the same patient, but we can have an additional value of this second tracer that is not commercially available at least in Europe. This is the example of bone lesion with this tracer. And here we have a comparison between androgen receptor and estrogen receptor in SUV max. I think that the correlation is better in estrogen receptor, but also androgen receptor has a good correlation. Now we move to somatostatin receptor because in case breast cancer has neuroendocrine compound, we can, I think as nuclear medicine physician, we all know the role of nuclear medicine in neuroendocrine tumors. So in this case, we can easily understand that in case of positive neuroendocrine, well-differentiated neuroendocrine tumor, the somatostatin analogs are very useful. And this was the one of opportunity is also to give therapy with somatostatin analog, that is peptide receptor radionuclide therapy on PRRT in case of neuroendocrine differentiation. This was one of the first paper with nice result in one liver metastasis before and after treatment. Here we have the imaging of the lutetium dotatate. And again, other image of lutetium dotatate. Again, this is before and after 2 cycles of lutetium dotatoc and the gallium dotatate before and after the treatment, the image. You see the good result in this neuroendocrine breast cancer. We can also, in case of neuroendocrine, we can look at the gastrin-releasing peptide GRPPR. This is also something research. And in case of positivity of the receptor or negativity of the receptor, we have different imaging features. If we look at the result after treatment with, you see, 177 lutetium RAM2, we have probably good results. I'm not so expert to say if it's a good result, but probably yes. Now we move clearly to osteoblastic activity. That is a big aspect of metastatic breast cancer. You know that we, as nuclear medicine, we have our best weapon is probably the bone scintigraphy, but there are other possibility to look at bone, and we will see the first is the comparison between classical bone scan with SPECT, with fluoride PET or FDG PET in 30 patients, and the results are clearly that the lesions are best analyzed when we used a combination of fluorine and FDG. This is possible in 2 methods, either making 2 exams or also, and this was the case of this study, in injecting to the patient the 2 tracers at the same time. The advantage is that you will not miss some low activity bone metastases that are seen only by fluoride PET. This is an example of bone normal plan bone scan and SPECT-CT. And this is other patient with bone scan and FDG, a comparison between bone scan in A and FDG in B and D. And this is an example of bone scan before and after radium treatment, because clearly if a patient has bone metastasis, we can give treatment specifically for bone. That is, one is radium chloride, and we see in this example the patient before and after radium treatment, followed up by SPECT-CT. Here we see at the basal level and after 2 cycles of radium chloride, with a nice response for the majority of the patients. If we speak about bone, if we speak about androgen, we can also remember, and this is something maybe the most important, in my opinion, message of this talk, is that in breast cancer there is also prostate-specific membrane antigen that is not so specific for prostate as it looks, or as the name seems to be. So we can eventually do some image and also, why not, treatment with PSMA for breast cancer. Here is one example of the presence that illustrates the presence of PSMA receptor in breast cancer, not only in prostate. And this is the image of the month of 2015 EGNM, where gallium PSMA was used to check for breast cancer. And you see the comparison with FDG, that is in the second level image. You see that the correspondence is very nice. So the interesting of this is that we can use PSMA also for a treatment. So these are other comparison between FDG down and gallium PSMA up. So this other, this is a patient with that was treated, and the follow-up was done with bone scan and PSMA. And this is brain metastasis seen on gallium PSMA in breast cancer. This other imaging that show the positivity, histological positivity of PSMA in breast cancer. Here we have the receptor status. And so finally, the idea is to follow up the treatment, is to give prognostic value, and to give also a molecular feature of the tumor. If we look at estrogen receptor, androgen receptor, PSMA, neuroendocrine tumor, we will have the answer without doing invasive procedure, but just making a scan. I think this was my last slide. In conclusion, so is the prognostic value, the therapeutic use of PSMA and radium, that is something radium known, PSMA maybe less known, and the fact that we can match the tumor heterogeneity of breast cancer. So thank you very much for your patience.
So thank you, Francesco, for this comprehensive overview of the potential of the many different nuclear medicine imaging procedures in breast cancer. Also for the message that we should look for a new name for PSMA, because it's not that prostate specific as we thought in the beginning. Are there any questions from the audience? Then, if not, I would like to ask you to present your own presentation today on sentinel node procedures in breast cancer.
Yeah, I have no disclosure in this case. My presentation is on sentinel lymphoscintigraphy in breast cancer. So we'll give a short introduction, then the present is the guidelines we did with ENM, and also some future trends. I have no conflict of interest in this item. So my presentation is based on this article that was published in 2013, so rather old. We will probably renew one. That was ENM and SNMMI practice guidelines, so it was done in conjunction of the two major nuclear medicine societies. So this just, breast cancer is the most frequent cancer in women, and staging is essential for prognosis and treatment, and therefore we are looking for sentinel lymph node. There is no imaging modalities accurate enough to detect in in microscopic, clearly, way lymph node metastasis. That's why it's important to make lymphadenectomy. The problem of axillary lymph node dissection is that there is main complication, pain, paresthesia, infection, lymphedema, mobility. Therefore, the sentinel lymph node mapping and biopsy is the method of choice in this case, because it allows accurate staging, may also detect non-axillary sentinel nodes, and minimize the number of unnecessary axillary lymph node dissection. So it's the routine technique since, I think, 20 years or maybe more. The indication you will see in this table, the common indication are in green and yellow. The only where is not recommended is the inflammatory breast cancer. For the controversial, we will see at the end all those aspects, if it's useful or not to do. We will see also some technical aspect, because this is a nuclear medicine congress, so I have to speak about injection modalities, volume, activity, particle size, time between injection and imaging and surgery. So for the precaution, clearly pregnancy is not a contraindication for sentinel lymph node, so we can theoretically, is good, yes. We can theoretically do the exam for pregnancy. Clearly, in some case, in the majority of cases, radioactive sentinel lymph node is combined with blue dye, and blue dye is actually contraindication. For the nursing mother, the lactation should be suspended for only 24 hours, not really for the milk contamination, rather, or if it is very low because of free technetium, rather than for exposure of the gamma activity. The surgeon and nuclear medicine specialist should have a specific training. This is fundamental. So if you have to start the procedure, you have to at least make a minimum of 30 procedures with both techniques, sentinel lymph node and lymphadenectomy, because only in this case you will succeed the best success of your technique. We should clearly have a look at the quality control of gamma camera, but also think of quality control of gamma probe. This is something important because I know, our physicists think every week to look at the gamma camera, but the gamma probe is in the surgical room, and so they don't go there. But they have to think about this because this is also fundamental, because it's the main tool of our detection. There is no special preparation. The injection is not so painful, so we can do without lidocaine. These are the radiopharmaceuticals that are used in Europe or elsewhere. They are very unspecific. These are the common. There is a new one that I will speak later on. And the common are really unspecific because they are exactly the same that are used with small or different size in lung perfusion scan or in spleen or liver scan. What is so the uptake is completely unspecific. The uptake of a sentinel node doesn't mean that the sentinel node is pathologic. For this, when we speak about false negative sentinel node, this doesn't mean that there's a sentinel node that does not cancer, but that means that in the lymphadenectomy there is a lymph node that is positive, while the sentinel node that we pointed up to the surgeon is negative. So this is the only way to detect false negative is to do a complete lymphadenectomy. If we think about the failure of the method is when you don't see any sentinel node. So this is not a false negative, is that we don't see anything. The quality control of the injected radiopharmaceutical should be bigger than 95%, otherwise we have too many free technetium So the injected activity, there are variable activity in the literature from 1 to 10 millicuries. But what is important to notice is that the more you inject, the best you see. Clearly, we have to deal with the radioprotection issue, not only for the patient, but also for the surgeon that has to do several sentinel node procedures per year. So the activity recommended by, and when you see this logo, means that is the guideline recommendation. In the same day is between 5 and 30 megabecquerel. And if we do the day before, we have to increase because we have to think about the radioactive decay. The volume should be physiologic, so between 0.2 and 0.5 milliliter, not more. Because if less, the drainage is low, and if more, we can disrupt the local lymphatic and do something that is not physiological. And therefore, we can look at some lymph nodes that are not in normal case sentinel node, but they will become sentinel node if we inject too much. What is very important, and I think this is one message, the main message of my talk is this one, is the fact that in the breast there is essentially two drainage patterns. The first is the subareolar SAPE plexus that goes to the axillary region, and the second is deep lymphatic that goes to extra-axillary region that end practically to the internal mammary chain. That is the main probability of deep lymphatic. So you have, if you want to see extra-axillary lymph node, you have to inject in deep. If you inject only superficial, the probability to see extra-axillary chain lymphatic is very low. However, the SAPE plexus is a circular plexus. So whenever you inject, you will get the sentinel lymph node of the breast. That is the sentinel lymph node of the axillary sentinel lymph node of your cancer. So if you inject in a superficial way, you will get anyway the axillary lymph node, the right one. If you inject in the deep, you will get other, as said, other lymph node. But to be sure that your lymphatic is the right one, you have to inject as much closer as tumor as possible. So you can't inject in deep anywhere in the breast like you did for superficial. You have to be careful and to inject near the lesion. That's why if you inject deep, you need either to make a nice palpation of the breast or to do with the help of ultrasound or mammography. Otherwise, you risk to have a sentinel node that is not the sentinel node of your breast lesion, but is the sentinel node of the point where you injected. It's a little bit, in order to understand, if we think about melanoma, you inject clearly near the scar of the lesion. If you inject in another point of the body of the patient, you will get sentinel node, but it's not the sentinel node of the melanoma lesion. This is. So the technique of injection are several, from intradermal, subdermal, subareolar, and perioral. These are superficial injection, and peritumoral and intratumoral are deep injection. The superficial injection are clearly easy to perform. The deep injection are more complicated, but they are the only one that allow the detection of extra-axillary nodes. This is an example of superficial injection, and if you inject, you have 99% of getting your axillary lymph node, and practically 0% of other lymph node. And this is an example of deep injection with ultrasound guided, and in this case, you see the percentage of more possible subclavicular, intramammary, internal mammary chain lymph node. For the guidelines, the injection method does not affect the identification of axillary sentinel lymph node. So if you look only at axillary lymph node, you don't need to make complicated injection. This is also an important message. If you're interested only on axillary lymph node, you just inject in the superficial way. If you want to look at other lymph node, then you have to do deep injection with complicated method. But is internal mammary chain important in breast cancer? This is not a very defined answer. We don't know. We know that the higher incidence of distant metastasis is present if the internal mammary chain is positive, but there is no difference in local region relapse nor in overall survival. Furthermore, the internal mammary chain surgery is a very not easy surgery. The surgeon should be aware that the morbidity is higher. So if we limit the morbidity of the axillary, I think we should also think of limiting the morbidity of the rest. What is, however, very specifically pointed out by this article is the fact that you have to irradiate generally the breast after the surgery, and generally you irradiate also the internal mammary chain. So in case of left breast, if there is no internal mammary chain uptake, you can imagine that there is no sentinel lymph node, and so that there is no possibility of metastatic spread, and so you can eventually spare the internal mammary chain in breast cancer and spare also the dose to heart. So one maybe intelligent utilization of the deep injection without doing the internal mammary chain check by surgery is just to see, and we have, as said before, a chance over 20% of positivity, that there is no sentinel lymph node in internal mammary chain, especially in breast cancer, in left breast cancer, and therefore you don't need to irradiate, and so you spare the dose to the heart. The imaging modality that are used in sentinel lymph node are planar, sometimes with some cobalt fluid, SPECT-CT that are the one that are preferred by the surgeon that likes very much the image, clearly, and the possibility to give the landmark. For the other possibility is nothing at all. And there are some nuclear medicine departments that do only the injection and send the patient to the surgery, especially if the surgery is planned the same day. There is no consensus on the guideline, even if the imaging are recommended, and in particular SPECT-CT. The incidence of localization of sentinel node, as said before, is 99% if in axillary, 20% in internal mammary, 4 clavicular, 2 intrapectoral, and 7 intramammary. These are the percentage if you inject in the deep, clearly. Otherwise, you have only the first line. There are some factors that explain the non-visualization of sentinel node. The first factor is the age of the patient. The second is the body weight, especially, and the third is the tumor location that is not in the upper outer quadrants. So in this case, there is another possibility, is when you have non-palpable breast lesion and the patient went first to radiology to make the wire localization. So the wire localization is also a factor that limit the diffusion, the lymphatic diffusion of the breast if it's done before the scintigraphy. So normally what we recommend is to do first the scintigraphy and secondly the wire localization, even if the radiologist is not very happy because the dose to his finger is higher. The cause of non-visualization can be the tracer concentration. If you wait, for instance, from between 1 hour and 20 hours, you see, in this case, the lymph node that appears later. SPECT-CT can also very well help. Here, in this case, we don't see anything in planar, and you see an axillary and intramammary lymph node in SPECT-CT. So SPECT-CT is also useful for that. The advantage is sensitivity. Clearly here we see only 1 lymph node in planar and 2 in SPECT-CT. The other is specificity, because for instance, in this case, we have enlarged lymph node that is a very suspicious lymph node, while just one part of the lymph node is uptaking. So this is probably a lymph node that has metastatic invasion. So we can already say to the surgeon, the patient is probably positive. Anatomic information, we can measure the deep of the lymph node. We can give also the information on the level, Berg level of the axillary. So we have, if there is no consensus in imaging, the imaging is strongly recommended. The patient position is supine or prone. The time we should do 2 images, one early and one late, and parameters are indicated there. The SPECT CT indication is when the planar imaging are difficult to interpret because of unexpected, unusual drainage pattern, because of no or poor visualization of the drainage. The advantage is a better contrast, spatial resolution. We have not to forget that we do SPECT CT, so we have attenuation correction. So the images are really much better for deep located lymph node. The problem is the cost, the added time of the procedure, the additional radiation, and the fact that we can do dynamic studies. However, in the guidelines, the hybrid imaging with SPECT and CT improves the localization of sentinel node and reduces the misinterpretation of image. So if you can, I would suggest to do. During surgery, we can inject blue dye. The surgeon likes to keep this method, but is not, obviously is not a must. The idea is to look for hot and blue sentinel node. Radioactivity cannot be seen, can only be heard by the gamma probe. So if the surgeon likes to see, he likes to see that the lymph node is blue. Then we make the exeresis and the analysis of the lymph node. During surgery, we recommend palpation to avoid false negative result because of looking for suspicion lymph node, even if they are not hot or blue. There is 1 to 2% of failed sentinel localization. So this is also the learning curve. At the beginning, you start with 10, then you go to 1-2%. And this is something that exists even without, with SPECT, even with gamma probe, we don't find. So the current standard patient care recommend axillary lymph node dissection in these patients. Radiation safety, the radiation dose to the patient, the exposition to the staff, and the contamination. For the dose to the patient, we said before, there's not much. What is important, because you see more than 95% of the injected dose is in injector site. So the effective dose to patients is 0.3 millisievert. What is maybe more important is the dose to surgical staff. That is less than 2 microsievert. However, the dose to the hand can be high, less than 20 microsievert. So the surgeon should make about 2,000 operations in order to reach this. So that this probably is never happen. And for the pathologist also is even less. The surgical swab may contain up to 10% of the injected dose. This is an important message because you have to take care and keep back to the nuclear medicine in order to keep the activity at least for 10 half period. So it's about 60 hours before releasing in the normal waste. What is not clear, big tumors. This is something that is not common in Europe, but in some low to middle income countries, we see patients with very big tumor, and sentinel node is possible to do also in this tumor because we demonstrate that the false negative rate and the axillary recurrence was similar to the smaller tumor. So the practice is feasible. The second is the multifocal and multicentric tumor. In this case, the false negative rate is higher. However, the reported axillary recurrence rate are acceptable. In this case, clearly, the deep injection has not a big sense. You have to inject in the skin. For DCIIS, normally the definition is of this ductal carcinoma is localized. So normally, by definition, there is no metastasis to regional lymph node. However, it has been proved that this invasion is missed up to 40% of patients. So we can recommend sentinel node biopsy, but only in patients that are undergoing mastectomy, so that we are sure that we don't miss up some false DCIS. For suspicious palpable axillary node, that are patients that come for sentinel node procedure and we pulp some axillary node. In this case, there is not a contraindication because 40% of cases may be negative, big lymph node. So we can do sentinel biopsy in a patient with palpable nodes. The best would be to make first fine needle aspiration biopsy of these nodes in order to be sure that they are apparently negative. For internal mammary, there is, as said, there is no consensus on the importance of the detection of internal mammary or other extra-axillary nodes because there is no difference in survival on this patient for the moment. So this is an issue that requires further classification. For people who had already a biopsy or breast surgery, the lymph drainage is changed clearly. But probably we think that the new sentinel node will reflect the situation of the metastatic lymph node. So it's probably a good procedure also for this. However, we have to take care of. For patients with neoadjuvant chemotherapy, this is a big topic because if we do you know that neoadjuvant chemotherapy means to do the surgery after the chemotherapy. The problem is that if we do surgery after chemotherapy, the sentinel lymph node may become negative just because of the chemotherapy efficacy. We can do sentinel node biopsy just before neoadjuvant chemotherapy, but this means to do 2 times surgery and might postpone the treatment. After, there is an underestimation. So we have to know those factors. This is also an issue that has no solution for the moment. Now we move to the last minutes to the latest technological knowledge. First of all, method, and second, radiopharmaceutical. Like always in nuclear medicine, we go for, in the future, for changing, improving the method and improving the radiopharmaceuticals. For the method, the first is not something new, is FDG. So should we do FDG in this patient? Yes or not? If we don't do FDG, we go to the classical sentinel node procedure. If you do FDG, then if there is a pathologic uptake in some axillary or also a metastatic uptake, we don't do the sentinel node, clearly. If yes, we change the treatment strategy. So this FDG is not recommended clearly, but we can do that, and we can have an idea in case of positivity of extra axillary or axillary lymph node. This is a case of unexpected bone marrow and axillary metastasis. This is a case of clinical suspected axillary involvement. We did FDG, and so this we can do, like instead of doing the fine needle aspiration biopsy, if there is a large axillary node, we can do FDG. Now, the second aspect is related to portable imaging devices. This is called Sentinella. Is an interesting device because you can use it in the surgery, so you also don't need to do the imaging before the surgery. You do the imaging during the surgery. And this is a case of a patient who has breast cancer, and you see the arrow that doesn't point out the lymph node is more up, but I don't think that I can show you like this, but however, is in the upper part of the big lesion, and you can check for the completeness of sentinel node removal. Another aspect is the so-called freehand SPECT. In this case, you turn the probe around the patient, and there is a tracking target positioned on the probe and on the patient that shows you exactly the position of the probe and the position of the patient, and so can virtually reconstruct the space around the patient and the hot spot in the patient. So this is really interesting because it gives to the surgeon an idea of the virtual reality, and you see that in a screen, the surgeon can check the lymph node, that is the point where the finger of the surgeon, because it was reconstructed by this freehand SPECT. So it's something that could be interesting to use. For radiopharmaceutical, these are the common, but the new radiopharmaceutical, we can use some non-radioactive, like fluorescent, that is indocyanine green, that has a very slow, limited size, a little bit like blue dye, and also small, tilmanoset, that is another tracer, a new tracer. And the possibility also to combine both with a cocktail. The tilmanosept is a receptor targeting agent, so it's not at all like the colloids that are non-specific. This one is specifically directed to macrophage. So the uptake is specific. The advantage is the longer retention in lymph node, lesser migration, so it goes only in the first lymph node, rarely in the second echelon, so you see really the sentinel node. There is a high count rate, and we think, it has not been proved, but we think that the patient who has lymph node metastasis has also higher macrophage activity and so higher uptake. So we can also point out the positive lymph node. The only problem, but is not a minor problem, is the higher cost, because the normal method costs about $10. This one costs $1,000. So it's 100 times more than the normal method. I think that this is really a limiting factor. It's a pain, but it's like this. This is an example with anterior view. You see, after 10 minutes, you have a very nice uptake of the lymph node that is in the axillary region. The other advantage is the fluorescent tracer. Fluorescence is interesting, especially for internal, like pelvic lymph node in gynecological or prostate cancer, but can be used also for breast cancer. The advantage of the fluorescence is that the surgeon can see. The surgeon likes to see it. That is, the fluorescence can eventually replace the blue dye. The problem of the fluorescence is given by the scheme in the bottom of the slide. You see that the fluorescence signal don't go out more than 1 centimeter or half centimeter, while the gamma go out from the patient. So we can look at the gamma signal with the gamma probe outside the patient. We have to look at the fluorescence just if you open. So this is a big problem. And the other non-radioactive tracer is the paramagnetic particles that are also very interesting because they are not using radiation, even though our radiation dose is not very high. There are some interesting paper. The problem of those paramagnetic particles is the tattoo of the skin, because this is iron and is exactly the same compound of the tattoos that are used for the normal people who want to make tattoo. So thank you very much for your attention. I finished in time, I think, and I'm ready for a question. Thank you.
Thank you, Francesco. Are there any questions for Francesco?
The biggest challenge is to get the patient on time to theatre. The biggest complaint from the surgeon is if we hold the patient back. In our department, we've started to do upper limb exercise to increase the rate of discovery of the node. Do you have a comment about whether we should be doing that? Certainly in internal audit, we have shown it objectively that we do detect the nodes faster.
Yeah. The one method could be to do the exam before. I know the day before. I know that this is not appreciated by the surgeon that likes to make, because now you know this surgery can be done in a whole day hospital. So the patient came in the morning and go out the evening. So this is very interesting, and if the patient should come the day before to make gamma imaging is not very good. But on my opinion, the fact to do very quickly and to have no time is not very good. So I recommend maybe to use the gamma imaging in the surgical room in order to be sure that you have enough time if you don't want to make the image the day before. It's an additional cost, but it's very interesting because it can be used by, with several sentinel node technique.
We do both subareolar as well as intramammary in the region of the tumour. And in about 1 to 2% of our patients, we actually see 2 different sentinel nodes.
Of course.
Yeah.
I agree, clearly.
Because you said that if you just do subareolar, then you're always going to see the correct axillary sentinel node. But in about 1 to 2% of our patients, we have two separate auxiliary sentinel nodes, and then we tell the surgeon take them both out.
Okay. Yes, this normally is. I don't know. Why are you sure that the 2 sentinel nodes are related to the fact that you inject in deep? Because maybe the 2 is only the...
You can see the lymphatic channel going from the injection site. We've just had that publication accepted. You can see the track. Sometimes you see the 2 tracks and they go to one node, and sometimes you see the track going to 2 separate nodes.
Yes, this is very interesting. I think you should publish, because we can change the guidelines in case, because clearly you have, this is an information. I say that there is only 1 axillary, but you prove that maybe there are 2. Yeah. Thank you.
I would also like to take issue with your comment that for axillary nodes you can inject anywhere. I'd refer you to the European Journal of Surgical Oncology, Spillane, 2013. We did a multi-centre trial that showed discordance between periareolar or subareolar injection and peritumoral injection, and this was not only for the internal mammaries, but it showed discordance, a high rate of discordance also for axillary nodes. When you use the planar and the SPECT CT, you can pick the difference in the 2. We injected subareolar 2 days before surgery and looked at it. We then injected peritumoral on the day of the surgery, which is what the surgeons used, and there was a high rate of discordance, including in the axilla. So the recommendation was very strongly for the majority of patients should be having peritumoral injection if you're actually looking for the node that's draining the tumour. Yeah. This is also is my feeling. I present the guidelines. That the guidelines is clearly is not the truth. Is expert how to say conclusion. But I also do only peritumoral injection, because I have the feeling that the peritumoral injection is the one that gives the best result. Also because we are very much interested in the intramammary chain for the irradiation reason I showed you before, and I think that is the most physiological approach. Thank you.
Okay, I If there are no more questions, oh, there's one more, sorry.
You recommended that for sentinel lymph node biopsy for DCIS, it should just be in the context of mastectomy.
Yes.
Are there other contexts, for example, like, say, a very large DCIS lesion in the left upper outer quadrant that's high grade, etc.? It's reasonable there to also be doing sentinel lymph node biopsies.
The recommendation was done if we do mammography. That means this is, I think it's fundamental to make sentinel lymph node before, because otherwise you have no more the possibility to do after. But for the other case, it's possible to do clearly. So it's clear. But in this case, you inject in the superficial, you don't inject in deep.
Okay, I'd like to thank Francesco and both our speakers for an excellent session. Thank you.